Good afternoon or good morning, depending on where you are. My name is Jeff Adest. I'm here with Sandy Jensen to talk to you again about FTCA. I was just reflecting in the last few minutes while we were preparing for this presentation that last year when we gave you this presentation, it was just when COVID was beginning, and I went on somewhat of a rant about how it's ridiculous that the federal government is bothering you when you're trying to take care of patients to worry about having to submit an FTCA application. And I guess we've come pretty far in a year in terms of where COVID is, right? No one realized back then what it was going to turn into and how crazy it was going to be. And I'd like to believe, and I know that probably depends on the state and where you are, that we are hopefully seeing the light at the end of the tunnel in terms of coming out of it. And hopefully by the next time we speak, everyone will be in much better shape in terms of having given out the vaccines, and the world will get back to at least semi-normal. I don't know that we're ever going to go back to completely normal, right? In health centers, you still have to go into work every day. For some of the rest of us, I have not been in the office in about a year, so I've gotten used to working at home. It was very hard for me to go back to work again. So like usual, before we get into the main topic, I just wanted to spend a couple of minutes talking about a different topic, which obviously is the vaccines. I'm not going to get into state-specific issues because there are people from very many states on this presentation, and we thank you for having so many people on. But I just want to talk globally about the vaccines and about things that you should be thinking about as you're giving them out. Now, some of you are probably shaking your head and saying we've been giving them out already for 2 months. Why is he talking about it now? And that's fair. Like I said, I can't pick and choose and only talk to a few of you because I think many of our clients are first starting to give them out or actually have not even begun to start giving them out yet. So I'm going to talk for a couple of minutes about it. So in most states, you have a state program whereby the state or the city or the county is giving you vaccines to give out. And now we also have the federal program whereby HRSA started out with 25 health centers and is now expanding to about 700 health centers over the next 6 weeks. They announced who the health centers are over the last couple of days. You should be able to find it on the website. If you can't, you just send us a request and we'll send you a link to look for it. If your health center is not on the list now, I would suggest that you reach out to your project officer to find out why you're not on the list to be getting the federal vaccines over the next few weeks. So just a few things about the vaccines, questions that have come up that I'll throw out to people to consider. First of all, even with regard to the federal vaccines, right? So you think federal government told me I could give it out and it's no problem. And there are federal rules about who can give out vaccines, which very often are different from the rules in your state. The federal rules tend to be more lenient than the ones in your state, but unfortunately, without going into a constitutional law lesson, the way it works is that just because the federal government says that I could give out a vaccine, even though I'm not licensed and not trained and not anything, I'm not saying they actually say that, but theoretically, does not mean that you can do it in your state because you have to follow your state rules as well. So what actually ends up happening, right, if you're one of the 25, FQHCs right now that are giving it out, you have experience with this. You have to comply with your state rules for who's eligible to get it, to give out the vaccine and who's eligible to get it. Then you also have to comply with the federal rules about who's eligible to receive it and how you give it out and reporting. And in some cases, you now have double reporting, right? The reports to your state as well as reporting to the federal government. But importantly, you need to comply with the rules of your state with regard to who can get it. So just using New York as an example, even though the federal government said that pretty much anyone can get it, in New York, unless you're above 60 or have a chronic condition, you still can't get it, even though in many other states, my understanding is that anyone above 18 can get it. So I will say that for myself, I have not received it yet, and we are still, it seems like a few weeks away in New York from the general population being eligible to receive it. So you still need to comply with those rules, and you need to comply with the reporting rules in your state. Other things to consider. So many health centers have called us about, okay, can we be giving out the vaccines off-site, right? Instead of just doing it in the clinic, we want to have a vaccine drive where we're going to try to vaccinate, 500 people today or 1,000 people today, and can we do that off-site? So from a federal HRSA perspective, the answer is yes. HRSA has been very clear that it can be done off-site, does not have to be one of your specific locations. They do say that if it is going to be a more than temporary site, right? If you're going to use it every day for the next year, then you probably have to add it on Form 5B. If you're doing a drive where you're going to use it for a couple of days here and a couple of days there, you do not have to add it on Form 5B as a site. You do have to add vaccinations, or immunizations, or health fairs, at least one of those, onto your Form 5C. And you want to do that because you want to make sure they have FTCA coverage for it. But like the same thing as I said before with the vaccines, you also need to worry about your state laws. In certain states, right, this is treated no different than a health fair, which you can go out and give. In other states, the state is being a little bit stricter about it and saying that, no, this is not a health fair, and if you're doing mass vaccination, you need to get approval from the state. So you need to go back and figure out, and we're happy to help you. I'm not going to sit and talk about specific states, but in certain states, you need to go back and get that approval to be able to do it. Other things that are important, again, is, like I said before, figuring out who is allowed to give it in your state, because it's different depending on the state that you are in. Also, there may be rules, right? So what we saw happen was at the beginning when people started getting vaccines, and someone heard that XYZ health center has vaccines, and all of a sudden you had people coming from 2 states away or 5 states away to be able to get it, flying in to get it, coming from out of state to get it. And what many FQHCs have done, and in certain states, again, the state requires, is that you only give it to patients in your service area. Now, one of the things that's also come up is, can I say I'm only going to give it to my pre-existing patients? And HRSA has said to that, you cannot say that, right? If someone who is in your service area and shows up for the vaccine, you have to give it to them as well, subject obviously to having enough vaccines available. I will mention again, which I mentioned on a previous presentation and got some, people reacting with shock. At the end of the day, I guess I'll take off my lawyer hat for a minute and be my person hat for a minute, right? In states where you still have crazy governors telling you that at the end of the day, if you have extra specimens, take them and throw them in the garbage and don't vaccinate people. My personal belief, again, not speaking as an attorney, is that that's just plain crazy, and that you find someone to give it to. I will tell you that I have gotten a couple of calls from people saying, if you could be here in the next 20 minutes, we could give you the vaccine because we have some extra at the end of the day. You should obviously plan to have a list of people to be able to give it to, but don't be throwing them away if you could find someone who can get the vaccine, right? We have to take care of each other, and it just seems ludicrous that people are saying throw them away rather than giving them out. The other thing is, and we're going to talk about this more as it relates to FTCA, is we are seeing more and more volunteers, right? People are coming out to help you give out the vaccines. And you just need to remember that FTCA covers the health center and its employees and certain contractors. It generally does not cover volunteers unless you apply specifically. So when we get to the end of the presentation, and we usually skip over the volunteer section and just spend a minute on it, we're actually going to spend more than a minute today because I think it is becoming more important. Okay, so that was my vaccine spiel. Now we're going to turn to FTCA. I will tell you that I still feel like I felt last year, which is that it's ridiculous that you have to turn away from taking care of patients to have to submit an FTCA application this year. I don't know if anyone from HRSA is on. I would feel very comfortable saying this straight to their faces if they are on, right? It just seems like they should have just extended it and got some kind of waiver to extend it for another year because you have other things to do rather than worry about this. Unfortunately, because they did not, you do have to worry about it. The very good news this year is that unlike last year, they did not change anything this year. So the application is essentially the same application as last year and essentially has the same requirements as last year. So it's not like you have to go out and start doing something different than you were doing previously. I will tell you at a very high level that I think the biggest issue that people are going to have this year, rightfully so, is that a lot of people went untrained this year, right? Because you were busy worrying about, trying to keep people alive and trying to keep your health center functional and not go bankrupt, right? There are many health centers that unfortunately ran out of money and did have to close up. And so you're trying to deal with all those things and deal with PPP loans and all the other grants and trying to figure out all the rules about it. And our experience has been that many, if not most health centers sort of let the risk management type training fall to the wayside and may have let QA meetings fall to the wayside and things like that. So you're going to have to be, and we're happy to help you, I'll say a little bit more creative this year in terms of coming up with QA activities. Now, you undertook tremendous QA activities, but whether you reported it is a different story. So if we are happy to give you some advice on dealing with that. And with regard to training, to the extent you have not done training, we have a training PowerPoint that we can make available. In normal years, we go out and we do the training. We can do it this year, obviously, through Zoom or some other, online system. And in the worst case, if you can't do that, we can still give you training slides that you could just give out to your employees and have them watch and sign some certification that they read it or watched it or whatever. So we do have those things available to help you with it, because I feel like, getting everyone trained, right? If you haven't trained anybody, get everyone trained between now and June is going to be somewhat difficult. So with that, I am going to turn it over to Sandy to walk through the details of the application.
Okay, great. So,
just one thing before Sandy starts, so we don't have to get this question. We will be sending out a recording of the presentation as well as the slides over the next day or so. So you don't have to submit questions saying, can we get the slides? You will get the slides and we'll send it to you. And you don't have to be sitting there with your cameras taking pictures of all the screens. So if you want pictures of me and Sandy, go right ahead. But otherwise, you don't need to be taking pictures of the presentation.
Okay, and the slides, you'll see when we go through them, and also when you get them, they're really detailed. And we did that on purpose so that you can refer back to them, and they'll help you if you have to revise any policies or if you had any questions. We can help with that as well. So as Jeff said, the FTC application is due this year, even though we're still in the middle of the pandemic. So the applications must be submitted by June 25th. Last year, they extended it. I really don't think they're going to extend it this year. So I think you should just count on a due date of June 25th and make sure you have everything all set so that you could submit a couple days beforehand just in case something happens with the system. And once again, they're providing the opportunity for FQHCs to apply for coverage for their volunteers. And as Jeff was saying, this year, it's particularly important after what we've been through. So the Federal Tort Claims Act, it basically provides malpractice liability coverage for your employees. And there's so much benefits to submitting an application and being deemed a federal employee for the health center and also for the employees of the health center. If there's a lawsuit, the lawsuit is against the federal government. It's not against the health center or the clinician. The clinician's not even named in the suit. If there's a judgment, it's a judgment against the federal government and not the health center. It doesn't apply to volunteers, so that's why it's important if you have volunteers to get coverage separately for them. It also doesn't apply to all contractors. I think Jeff was mentioning that as well. there are certain exceptions. I believe, for example, if an F2HC contracts with a hospital for cardiologists, the F2HC would be covered, but not the hospital or the cardiologist group. But there are certain exceptions where you could get a contractor covered. And basically, if you directly contract with a practitioner for primary care services, and certain other requirements are met.
Yeah, just on that point, it's important to note that it's come up many times over the years. So if you're contracting with John Smith, MD, and he says, instead of paying me, contract with John Smith, MD, PC, he most likely will not have FTCA coverage, even though he's the only person who works for that entity. So it's got to be with, him or her directly.
Okay. So this year, like last year, the application seems really easy. All you have to click is yes or no on many questions. However, don't be fooled by that, because the responsibilities behind those questions are very important. And when HRSA comes in to do a site visit, they look to see whether you actually are implementing your policies and procedures. And even the PAL this year, they note that during a regularly scheduled on-site visit, if they find any issues with the FTCA requirements, they can use that when determining whether you met the requirements in the FTCA application. So they could consider, even though you submit everything under the FTCA application, if you went through a site visit and there were any issues, they could determine that your application is incomplete. So it's really important that you have policies and procedures, but that you actually implement them. So again, the FTCA application is broken down into 4 sections. In some sections, you're required to disclose whether you have any active conditions or any other enforcement actions. And that's another way that they could determine that you shouldn't be deemed a federal employee for purposes of the FTCA. And once again, it has to be signed by the executive director or the CEO. So risk management is a very important topic for HRSA, and one that they particularly pay close attention to. So you must designate an individual responsible to oversee the risk management program. So this could be a person that holds multiple roles within your health center. It could be the compliance officer / risk manager. It doesn't have to be a person specifically dedicated to risk management only, but your position description has to include risk management duties. So if you have a compliance officer who does risk management, the duties should say oversee the risk management program, conduct risk management training, or ensure that risk management training is done. You have to have those words in there, because that's what they look to see whether the duties include risk management.
Right. I'll say it one time, and then I won't repeat it. Yes, I think Sandy mentioned this before. So if you need, for example, a risk management job description, we have any of the documents that we're going to talk about today that you need to have, we have samples of that are available.
Yeah, we review applications before they get submitted, and we review all the risk management policies and procedures, the diagnostic policies that have to be submitted, and also the minutes of your risk management. Oh, I need some water.
Okay, while Sandy's just taking a break for a second, I just wanted to throw out something else, not specifically relating to the application, but I think that FQHCs often forget, you fill out the application and then hopefully you don't have to deal with it until next year. But just keep in mind for FTCA, if someone is threatening to sue you, they can't sue you. So you can't be held hostage by them, right? They're saying, if you don't give me X dollars, I think you did something wrong, give me X dollars. If you don't, I'm going to sue you. You might, in some circumstance, decide you give them the X dollars because of some other reason, but the fact they're going to sue you doesn't really hurt you because they're suing the federal government. Again, that doesn't mean you should commit malpractice, because if you have too many claims, you could get kicked out of the FTCA program, but you don't need to be held hostage because of the threat of a lawsuit.
Okay, I think I got my voice back. I do not have COVID or anything like that. I don't know what's going on, but we'll soldier on. So you also have to submit proof that the risk manager completed annual healthcare risk management training, and that has to be within the last 12 months. And they like to see a progression. So if your risk manager did level 1 last year, they should do level 2 this year. So you have to attest that you have a risk management program to reduce the risk of adverse outcomes. So the program should encompass your entire health center. So the front desk staff, all of your departments, not just your clinical department, but your behavioral health and OB and dental health. So you have to make sure that the program is comprehensive. It has to cover risk management across the full range of FQHC activities. And these are patient management activities that are particularly important to HRSA. They include triage, so telephone triage. So a patient calls in and they'll tell whoever picks up the phone that, I'm having heart palpitations, I'm sweaty, I have pains shooting down my arm. And there should be a process in place where those are red flags so that immediate attention is given to that patient. It could be directing the patient to the hospital, but we were involved in an FTCA-specific site visit, and they said the actual procedure should be keeping the patient on the phone, and the health center calls the ambulance to have the patient transported to the hospital. But the point is you have to have policies and procedures on what happens when a patient calls in, or do you make 6 visits available during the day? What happens if a patient just walks in without an appointment? Missed appointments, intake. So again, with the patient management, we're going to talk a little bit about the FTCA specific site visit, because even though it's not specifically on point to the FTCA PAL and what's required in the PAL, these are what the site visit protocol basically explains what they're expecting when you say you have these procedures and policies in place. So if you had an FTCA specific site visit, you actually have to have written policies about all of these topics. Your risk management program has to include training for all staff, completion of quarterly risk management assessments, and reporting to the board. So when we review applications, we get the policies, we get the plans, but there's certain areas that we particularly find might not include everything that's required by HRSA. And it's any reports to the board or the minutes of meetings, because sometimes it doesn't include everything that they're looking at. So it's really important that everything that they require is included in the report and reported to the board. So completed risk management activities. What did you do during the year that addressed risk management projects or risk management assessments? How are you doing compared to your goals? So every year you have to identify goals that you're going to do for the coming year. And then quarterly, you have to assess how you're doing. Like, okay, in this first quarter, our goal was X. How are we in meeting that goal? What should we change? So your annual report should say, our goal was X, this is what we did, and here's where we are. It should address sentinel events, adverse events, near misses. So when we do these presentations, we'll always get a question on where does it say that we have to talk about sentinel events and near misses and adverse events. And HRSA has put out numerous webinars. They've put out the FTCA site visit protocol. There's different documents that they've put out where they're saying this is what they're looking for. It might not be spelled out in the PAL, but this is what they're going to look at if they come and do a site visit. So back to the annual report.
Okay, this is also, I'm sorry, one other area, right? You're required now at year end to report on achievement of your goals. give that, so that more than implies that requires that a year ago you set, in the middle of COVID, you went to the board and set risk management goals. If you did not, because you were dealing with COVID and now have to be able to have a report saying how you address your goals, I am not that loose to say in front of 145 people what to do. But if you want to reach out to us, we have some ideas for how to be able to respond to that question in the application.
Yeah, and when we review the report, many times there are no goals. There are no goals that have been tracked for the entire year. There's things that were done now, but no goals. So that is an issue. So in this annual report, then you also have to identify annual goals for the next 12 months coming up. So, and all of those bullets are scary because these are all the additional things that have to be included in the annual report. And if you look at it, it's really comprehensive. Incident information, near misses, adverse events, and sentinel events. And, Jeff knows, we'll talk to health centers, and there'll be huge health centers or very small. They have zero near misses. Sometimes, patient grievances have to be patient satisfaction. That's usually, but like zero near misses at all. Near misses happen. In fact, I was talking to her son, something unrelated, and near misses came up, and they love near misses because they said it's an opportunity to identify something that could have been an issue, but it didn't happen. So you have an opportunity to correct it without any kind of negative consequences. So there has to be like practices in place where staff feel comfortable to identify a near miss. So maybe there was like expired medication and someone almost gave expired medication to a patient, or a needle was disposed of incorrectly and someone almost got hurt. Nothing happened, but it was a near miss, and put something in place to prevent it in the future.
Right, and like Sandra said, it's very hard to believe that you could go through an entire year without having any kind of near miss, right? We see them a lot in dental, for example, right, where someone is about to do a procedure on the wrong tooth and realizes it, right? And I know that, most people, right, if they do something that was a near miss, they, think to themselves, okay, I got lucky, and they don't tell anybody about it and they hide it, right? HRSA has said, like Cindy said, we sat through some of the FTCA site reviews, and HRSA has told us straight out that if they come in and they find there were no near misses, then they don't believe that you have a robust FTCA risk management program, because it's just impossible. So try to push on. When we do our training for the physicians or clinicians, we try very hard to push on them to come up with some of them, because there's got to be things that come up during the course of the year.
Exactly. Yes. And I'm spending a lot of time on the annual risk management report, because when we get these, this is, again, the reports are really the ones that we struggle with. The second bullet, analysis and trending of data. So HRSA loves graphs and tables. And so what they're looking for with that one, say, like you could do trends on incidents. Maybe you had like a high number of needle stick injuries in 1 month, and then you put something in place, and then the next quarter that dropped. It's just showing the board in an easy format where you are with respect to this big risk management topic. Okay, so like the last few years, you have to upload your referral tracking, hospitalization tracking, and diagnostic tracking policies. And if you go on HRSA's website, there are documents that help describe what should go in them. We also have resources as well. So the hospital tracking policy, we list what's required. And again, this this came from various webinars and discussions with HRSA and site visits. This is what they're looking for when they look at hospital tracking policies. But more than that, what they want to see is that you've actually implemented it. And you would look at relevant departments within your health center. So, for example, medical, because medical, you would send patients to the hospital from your clinical staff, but also OB. Sometimes, OB patients are sent to the hospital right from the health center. So you have to make sure that you have hospital tracking policies that track when you send a patient to the hospital and then do the follow-up that's required. So in prior years, you were required to track hospital admissions when you sent the patient to the hospital, but also when they entered on their own, which was really burdensome. And the compliance manual changed that to say you're no longer required to track hospital admissions when the patient went on their own. So if you read the PAL, though, it does say that you're required to upload tracking policies that include procedures that are initiated by the patient. Or I'm sorry, procedures on hospital admissions initiated by the patient. But we reached out to them and they did agree that that's no longer required. So the referral tracking policy. When a patient is referred outside of the health center, you have to have a policy that tracks that referral. The elements of the policy include the referral type. Was there a specialist referral, or did the patient say, I would like to be referred to a specialist? You have to differentiate between urgent referrals and routine referrals, and what's the process for each. So for example, an urgent referral, you might have the health center contact the specialist directly and make the appointment directly. And then you would expect that report back to you fairly quickly. With a routine referral, you might give the patient the name of the specialist, ask the patient to contact the specialist directly and set up the appointment. And there might be a longer time within which you expect the report back. And there also has to be a process for timely provider follow-up. Here are all the requirements for the referral tracking policy. But again, the most important thing, you can submit a perfect tracking policy, but if you don't follow it, then you're really opening yourself up to liability, consequences on an on-site visit. So you have to identify someone that actually tracks referrals. They have to be aware of the policy, and it should reflect what they're actually doing. And diagnostic lab test tracking policy. So this has to apply to both radiology and lab testing. The elements are listed there. There has to be communication of the results back to the patient. Jeff and I always get in trouble for this, only because HRSA has said numerous times that normal results have to be communicated back to the patient. So sometimes we found that health centers will communicate abnormal and critical results, but not the normal results. Or it will be, if you don't hear from us, everything's fine. HRSA does not like that. The policy has to have some sort of process for communicating normal results. It could be like a postcard or a letter. I know one health center who just hired someone whose sole function is to communicate results back to the patient, all results. For abnormal results, your policy has to include communication to the provider, time frame of communication to the patient. So maybe within a few days, the patient has to be contacted. You have to document the contact efforts, including date and time, and any other information that's important. HRSA noted that the key is differentiating between abnormal results versus critical. So the critical results would be under different time frames. Usually, once you get, once you get a critical result back, everything has to happen quickly. You have to contact the patient quickly. The provider has to learn of the results quickly. You have to have procedures to contact a backup provider. So you can see what the thought process here is. A critical result is one that could have really detrimental effects on the patient. So what if the provider is out that day, or worse yet, is on vacation? There has to be a process for someone to review lab results or lab and diagnostic test results that come back. There has to be measures to contact the patient. And during an FDCA site visit, what HRSA explained to us was for critical results, if you can't contact the patient, they want you to contact the backup. If you can't, not the backup, the emergency contact. If you can't contact the emergency contact, there has to be some way to do a home visit, either contacting the local authorities or have the health center go to the patient's home to try to reach the patient. Okay. So again, moving on from the policies, you have to attest that you have implemented risk management operating procedures. So those include identifying the areas and activities of highest risk. And sometimes those areas are, self-evident based on what the scope of services are. So, OB is a high risk, dental is a high risk, just because of, OB, the issues with delivery, dental, infection control, those are high-risk areas. So what are you going to do to try to minimize or eliminate those risks? And that can be establishing or using clinical protocols. Clinical protocols are actually really important for HRSA. If you were subject to a site visit, they actually want you to turn in your clinical protocols for them to review. And so, a lot of people use up-to-date. That's fine, but you should have like a written document saying, that the protocols are up-to-date. We make it available to our providers. You give them access and a password. They could have it available to them. Sometimes it's available through the EMR. So whatever you do, for each department, you should have a clinical protocol that mirrors that. It could be medical staff supervision, for those that maybe need more supervision, and you found that maybe there were some, peer review, that there were some issues, they could be subject to supervision for a period. You have to have a process for documenting, analyzing, and addressing sentinel events, complaints, and near misses. And we talked about near misses. Setting and tracking your risk management goals, we talked about that. We'll move on. So Jeff was saying, annual risk management training. HRSA also noted that this was the weakest application submission. And, when we get these applications to review, what we find is the biggest issue is that not everybody completes it. Sometimes providers have appointments and they can't meet the scheduled training session. So, we try to work with that, and Jeff said that, we offer training as well, but it's one of the areas that they care about the most, and what they found was the weakest. So the training plan has to incorporate OB, and even if you don't do delivery, if you do prenatal and postpartum care, you need to have a training that incorporates these areas. Infection control is really big. You should have training on infection control, including dental equipment sterilization. And I'm just gonna, just as an aside about infection control, if you had an on-site visit, you have to make sure that your infection control policies are up to date, but also that you're implementing the policies, and there's some ongoing monitoring that could be like monthly or quarterly to make sure that infection control practices are implemented. For the site visit, they're going to ask for a log to show that, who's ever responsible for infection control has been going around observing that practices have been in place. And also they go beyond your policy to make sure that, you know, all the requirements for the CDC and OSHA, that all of those are met as well. For example, the hand hygiene training and monitoring program. So for the site visit, they look to see whether CDC requirements were met. And one of the CDC requirements was that hand hygiene training is given initially upon employment and then at regularly scheduled times thereafter. But one requirement said that the newly trained person had to demonstrate competency. So you have to show upon employment. So they have to be trained on it and then demonstrate competency. So you just have to be aware of all these different requirements and make sure that you're putting them in place before you get a site visit. So you have to upload your training plans and also the tracking documentation that shows that everything was completed within the last 12 months. You can't submit blank tools and documentation. Staff attendance has to be tracked, and it has to tie back to performance reviews and credentialing and privileging. So if you have clinicians who have not been doing the training, that has to come up in performance reviews or when they're up for credentialing and privileging. So risk management assessments, on a quarterly basis, you have to be doing assessments, and those have to include any data and trends like on incidents, any reports like incident reports. Again, you can submit risk management committee minutes to show that these assessments are done, but they have to be reflective of the last 12 months. These are requirements for the board. Basically, you have to make the board aware of this. They have to receive all of your assessments from the quarterly reviews that you've been doing. They have to provide approval for the risk management plan. They have to receive the annual risk management report and review it, and then you have to submit minutes showing that they did review it and receive it. Okay, moving on to quality improvement. So you're no longer required to upload your QA plan. And again, you just have to attest, and that you have to attest that you have QA procedures that address adherence to those standards of care, standards of practice. So going back to the protocols that I had mentioned before, and a process to identify any patient safety or adverse event issues. You have to have a process for assessing patient satisfaction and hearing and resolving patient grievances. You have to do quarterly assessments. We'll talk about those. And you have to share your reports to the board. You should be sharing your QA committee meeting minutes and all the attachments that go with it. One word about patient grievances, like near misses, sometimes we'll go to a health center and find there's no patient grievances, which seems like the near misses, it seems unbelievable. You want to have a process in place where there's, if a patient submits a grievance that's not handled informally, because some can be handled informally, but some rise to the level of a grievance that should be undergo more of a formal process. There has to be a way to track that and track what the resolution was. So for the assessments, this is another area where sometimes when we review applications, we find that the assessments don't include everything that should be in it. So QI assessments have to be done by physicians or other licensed healthcare professionals and use data pulled from patient records. So what is this? It's peer review. And so on a quarterly basis, you should be doing some peer review of your health center providers. That doesn't mean every quarter, every department gets peer review. It could be that you have a schedule and the first quarter you'll do like behavioral health and dental, and the second quarter you'll do clinical. But you should be doing something every quarter and reporting it back to the QA committee. And that should then be sent and shared with the board. You have to submit the most recent QI/QA report to the board, and you have to also submit your minutes showing that you, in fact, did share this. The QI/QA. Oh, actually, before we move on, I want to go back to the quality assessment. So peer review. So again, just to stress, this has to be done by physicians or other licensed healthcare professionals, and the purpose is to determine whether the standards of care were met. So sometimes what we get is, I guess the EMR can run reports, and it can say, okay, immunizations were recommended at this age, and the reports are run. It could be the QI/QA director that runs the report, and the QI/QA director is not a clinician, and the reports just really reflect whether certain performance metrics are met. That doesn't really equal to peer review. So you have to make sure what you're submitting really looks to see whether standards of care are met, and they're done by physicians or other licensed healthcare professionals. Okay, so to upload the QI/QA director's job description. Those 3 items under this bullet, make sure those words are in the job description. They specifically want to see this. And also the job description has to say that QI/QA activities are part of the individual's daily responsibilities. I apologize for going fast. I see we're coming up on the time. There are some governing board requirements. They have to receive the report. They have to be able to discuss it and share any feedback they have. And the compliance manual requires that the QI/QA plan be reviewed by the board at least every 3 years. So make sure that the board reviews the policy every 3 years, and that's all included in the minutes. Credentialing and privileging, and I'll just highlight some of the more important provisions for that. So you have to have a process in place to credential and privilege your staff. If any of the requirements in the FTCA, PAL, or the compliance manual are missing, then they're going to consider that you are not in compliance. So there's 3 categories of personnel that you have to make sure your policies cover. We find that there's usually no problem with LIPs and OLCPs. They're always mentioned in the policies, but a lot of times the policies don't mention OCSs, which is other clinical staff that don't need to be certified. And it really depends on your state. Some states don't require medical assistants or dental assistants to be certified. If that's the case, then they would fall under OCSs. If your state requires all staff to be certified and you don't have OCSs, I would still put in your policy, the health center does not utilize OCSs, so that they know that you just didn't forget about it, that you know about the requirement, but it doesn't apply to you. So these are requirements for credentialing. I would note for basic life support, we usually get questions on this. Basic life support certification is only applicable if your health center has identified that category of staff as requiring a life support certification. So if you require it of all medical assistants, but not of, let's say, dental hygienists, then you would require that as part of credentialing and privileging only of the medical assistants. These are additional requirements for privileging. For initial privileging, you can determine competence through training, education, and, if available, references. For renewal, you could do peer review, but you also have flexibility to determine privileging through a supervisory performance review. And the last dash there is important as well. Make sure that your policy includes a process for removing, denying, or modifying privileges if there's an issue with clinical competence or fitness for duty. Okay. If you have contracts with provider staff, make sure that your contracts include those two dashes on the bottom. They have to state that the providers that are being supplied to you are licensed, certified, or registered through a credentialing process, and they're assessed as competent and fit through a privileging process.
Right, that which means that if you're getting someone, you're getting those providers generally through a hospital or health system, they probably are going to do that. If you're getting the employees, through a regular private practice, they almost never will comply with those requirements.
Okay, so just a note that the compliance manual clarified that you're not required to employ your clinical staff. You can have contracts, but keep in mind the provisions that must be in the contract. So important requirements, you have flexibility to determine who has approval authority. So the board can approve, or you can have the medical director approve, but remember that there also could be state requirements on who has to approve your staff. Oh, and you can hire a credentials verification organization to do the credentialing activities. But again, you have to determine who has approval authority once those activities are completed. Okay, claims management. So the important things to remember about claims management is that you have to have a process in place to handle claims that come in. And that includes preserving all documents that could help defend against the claim or complaint, and immediately sending the service of process to the Office of General Counsel for Health and Human Services. So you have to upload your process as part of the FTCA application, and you have to make sure that those two points are included. So a process for preserving health center documentation. So what that usually means is you receive notice of an actual or potential claim or complaint. So not just an actual, but if you think something could possibly have a good chance of leading into a lawsuit, you identify the appropriate department or people involved and send like a litigation hold or something similar saying, make sure all of the documents related to this is maintained, that nobody disposes of any documents or records or policies or procedures that were in place at that time. You have to identify your claims, and for closed claims, you have to include certain information. Basically, what did you do for once the case is closed, not for any open claims, but once the case is closed, what did you do to try to mitigate this from happening in the future? You have to include the job description of the claims manager and a screenshot of your website that includes the deeming language. And the sample of that language is in the PAL. I would just use that exact same language and put it on your website or any materials. Also keep in mind if your patient population wouldn't normally access a website and it's known to you that they would not get this information from the website, you might instead consider posting it on the wall of the waiting area or some other way, some promotional material. Okay, so we just wanted to spend a couple minutes talking about the volunteer health professional coverage under the FTCA. So just because your health center is deemed an employee under the FTCA, that does not cover your volunteers. You have to sponsor a volunteer and submit an annual deeming application. And the sponsorship is volunteer specific. So if your volunteer is like Jim Jones, you have to submit an application sponsoring specifically Jim Jones. The system is open again for the sponsorship applications in addition to the FTCA coverage. So there's certain requirements that are necessary to qualify for sponsorship. The FQHC has to be deemed covered under FTCA. The volunteer, the service provided by the volunteer must be in the health center scope of services. The FQHC must be sponsoring the volunteer. The volunteer cannot receive any compensation at all for the service from the patient, the FQHC, or any third party. So there can't be reimbursement from insurance or Medicaid to the volunteer, but that doesn't apply to the FQHC. So the health center can still bill for the services provided by the volunteer, but the volunteer can't be receiving any kind of compensation directly. But you can pay the volunteer for reasonable expenses. If you're holding some sort of, vaccine event far away and the volunteer has to travel to it, you can reimburse for reasonable expenses, but they can't receive compensation for the service. Before the service is provided, the volunteer, generally the health center has to post a notice at the site where the service is provided, putting the public on notice that the volunteer is a deemed employee and of their limited liability. So this is similar to putting the public on notice, or the patients on notice when they're coming into the health center, that there's limited liability also from the health center standpoint. When the service is provided, the volunteer has to be licensed or certified. They have to maintain their credentials, and they can't let their licensure lapse. They have to be credentialed and privileged by the FQHC. So your credentialing and privileging policy that you have in place, you would have to also apply that to the volunteer. And HRSA did clarify that residents, students, and interns are not eligible for this program. So there's certain documentation that has to be maintained. That includes the credentialing and privileging files. You also have to enter into a written signed volunteer agreement. It has to acknowledge that the volunteer is not receiving any compensation, and it has to document each of the off-site activities for the FQHC. Okay, look, we did it. It's 3 o'clock on the nose. We got it all in.
Okay, thank you everyone for joining. For those people who submitted questions, we'll reply to individually to you with your questions, and we look forward to speaking to you soon. If you need help with anything relating to this, please let us know. Thanks.